I have the pleasure of introducing our first speaker, who will deliver the annual Stockman Lecture, today titled, Mind the Gap, What's Missing in the Education of Pediatricians. The Stockman Lecture was created by the American Academy of Pediatrics and the American Board of Pediatrics to honor Dr. James A. Stockman III upon his retirement as President and CEO of the American Board of Pediatrics. Dr. Stockman presented the inaugural lecture at the AAP conference in 2014. This year's presenter is Dr. Julia McMillan. Dr. McMillan is Executive Vice Chair of the Department of Pediatrics at Johns Hopkins Hospital. She served as Residency Program Director at Johns Hopkins from 1991 to 2012. Dr. McMillan has served as Chair of the Board of Directors of the American Board of Pediatrics and on numerous committees of the board, where she currently chairs the board's Strategic Planning Committee. Please join me in welcoming Dr. Julia McMillan.
Good morning. Dr. James Stockman has been, for me personally, an important teacher, role model, and mentor. He ably led the American Board of Pediatrics through an era of professional growth for that organization with the constant goal of improving the health of children. It's an honor to have been invited to give this year's Stockman Lecture on pediatric education and the workforce. I have nothing to disclose. Statistics regarding behavioral and mental health needs of our nation's children are not unfamiliar to pediatricians. 20% of children in the United States have a diagnosable mental health condition. 10 to 14% of children under 5 years of age have social and emotional problems that affect family functioning. 50% of adults with mental health disorders had symptoms by the time they were 14. Only 20% of children who need mental health and substance abuse services receive them. The prevalence of mental health conditions increases during childhood and adolescence. As many as 30% of adolescents will suffer from anxiety disorders by the time they're 18, 20% from behavioral disorders, 15% from mood disorders, and 20% from substance abuse disorder. According to a 2014 study by Hutro et al., the prevalence of childhood disability attributable to physical health conditions declined by 11.8% during the decade between 2001 and 2011, while disability related to developmental or mental health conditions increased by 20.9%. So who cares for all these children? According to the American Academy of Child and Adolescent Psychiatry, there are 8,700 child and adolescent psychiatrists in the United States with a projected need of 30,000. The average wait time for behavioral and developmental specialists is estimated at 14.5 weeks. The average time to see a child psychiatrist is 7.5 weeks. Pediatricians who see and understand the toll behavioral and mental health problems take on individual children and on families are in a position, by virtue of their ongoing trusted relationship with families, their understanding of the context of their patient's development, and their familiarity with the available referral network, to recognize behavioral and mental health problems, to intervene themselves in many cases, and to coordinate referral to specialists when that's necessary. But are pediatricians adequately prepared to recognize and manage what is arguably the most common group of conditions affecting patients in community practices? Many pediatricians themselves think they are not. The results of a 2004 American Academy of Pediatrics periodic survey revealed that although most pediatricians surveyed felt that it was their responsibility to identify a variety of behavioral and mental health conditions, many also agreed they should be prepared to manage those conditions. 70% of general pediatricians reported that they lacked training in mental health treatment. 65% lacked confidence in their ability to diagnose mental health issues. 65% lacked the ability to treat mental health problems with counseling, and 64% felt they did not have the ability to properly treat these children with medication. This 2004 survey was repeated in 2013, and although about 10% fewer pediatricians lacked confidence to diagnose and provide appropriate medications for mental health conditions, confidence with counseling was unchanged. In 1978, recognizing the growing and unmet need to address what was termed biosocial and developmental problems and the care of adolescents, the term that was called the new morbidities, the Task Force on Pediatric Education called for apportioning time in pediatric residency training to develop competence to meet those needs. Response to that 1978 recommendation was slow. However, by 1990, the program requirements for pediatric residency included a requirement for evidence of a structured educational experience in adolescent medicine, child development, child psychology, and the care of the handicapped child. It was not until 1991 that there was a requirement for a distinct structured experience in behavioral and developmental pediatrics that included didactic and clinical components. Those experiences were not further specified, and each program was left to determine their content and the level of supervision to be provided. By 2000, the RRC required each program to include a one-month block experience supervised by faculty with training and/or experience in behavioral and developmental aspects of pediatrics, as well as integrated experience incorporating child behavior and development, psychosocial screening and behavioral counseling, and referral as part of an ambulatory and inpatient experience throughout the 3 years of training. The 2007 revision reduced that requirement to the simple statement that a one-month rotation with appropriate supervision was required. Today, the requirements permit either a one-month block experience or an educational unit or 200 hours of a longitudinal experience, along with the requirement of a certified faculty member. Program requirements revised after 2000 have included no language specifying the content of developmental behavioral experience. They have not listed learning goals to be achieved by residents, and they have not mentioned the integration of behavioral and mental health throughout residency. Certification by the American Board of Pediatrics was first offered for pediatricians trained in developmental and behavioral pediatrics in 2002. Board certification was expected not only to give credence to the subspecialty and to help foster research and clinical care, but also to provide well-trained faculty members who could enhance the education of future pediatricians. According to the American Board of Pediatrics, there are now 720 board-certified pediatric developmental and behavioral specialists scattered not very evenly throughout the country. In the states colored in the darkest green, there's one for every 59,000 children, while in the palest green, there is one for every 300,000 and none in the white areas. As pointed out by Dr. Ruth Stein in a commentary published earlier this year, many of those developmental and behavioral faculty members are sequestered and siloed off campus and are increasingly seen only as people who take care of children who have special needs, children who are unfortunately undervalued by society, rather than as key faculty essential to the central departmental educational mission and critical to the successful delivery of care in all venues. Meanwhile, that month of required developmental pediatrics is not always even a full month. In a 2010 study by Sue Horwitz and others, 4% of graduating residents surveyed reported that they had only 1 to 2 weeks, and 28% reported that they were allowed to schedule vacation time during their developmental and behavioral rotation. When asked to self-assess their competence in mental health skills, such as diagnosing attention deficit hyperactivity disorder, depression, and anxiety, and managing or treating those conditions, fewer than half the graduating residents rated their competence as good to excellent, despite their near uniform agreement that as pediatricians, they should be responsible for identifying and treating mental health problems. Corey Green and colleagues surveyed pediatric program directors and found that the majority of pediatric training programs do not emphasize mental health training and are unaware of recently published mental health competencies for pediatricians developed by the American Academy of Pediatrics Committee on Psychosocial Aspects of Child and Family Health and the Task Force on Mental Health. The majority of program directors rated their residents' knowledge about psychosocial and pharmacologic interventions as average or below average. So if behavioral and mental health problems are such important concerns for children and families, and arguably for society at large, and if pediatricians feel it is their responsibility to help address those problems, what can be done to improve preparation of pediatricians in training, to equip them with the confidence and competence needed to screen appropriately, identify at-risk patients and families, diagnose and manage behavioral and mental health problems, and refer and coordinate care for those requiring more specialized expertise? The answer is not likely to be found in the accreditation guidelines from the Pediatric Residency Review Committee. The ACGME, which oversees that committee, has moved away from stipulating specific content of residency training and descriptions of competencies to be developed during individual learning experiences. Instead, the ACGME is encouraging residency programs to innovate to achieve overall competencies. Behavioral milestones have been developed for assessing these competencies in general, such as performing a thorough physical examination, communicating with families. But the context for assessment, that is, whether those milestones are assessed in an intensive care unit, the emergency department, or the residence continuity clinic, is not specified. A more recent concept in medical education is the Entrustable Professional Activity, or EPA. The idea is that within each specialty, there are routine activities that a physician should be expected to be able to perform competently and without supervision. A proposed list of 18 EPAs for pediatricians has been drafted by physicians representing the American Board of Pediatrics and the Residency Review Committee for Pediatrics, including Drs. Carol Caraccio, Joe Gilhooly, and Robert Englander. Once identified, the idea is that skills, knowledge, and other competencies needed to achieve entrustment will be defined. A curriculum will be created with those functions and competencies in mind. An assessment will occur to ensure that the trainee or pediatrician is capable of performing that activity competently and without supervision. Among the 18 activities proposed as defining the competent pediatrician is assessment and management of patients with common behavioral and mental health problems, requiring that each graduating pediatric resident be competent to assess and manage problems with common behavioral and mental health aspects without need for supervision would be the goal. It is a goal that has not been previously so clearly articulated. For decades, graduates of pediatric residency programs have been telling us that their training to care for children with behavioral and mental health problems has been inadequate. Once again, in a 2009 survey of pediatric residency program graduates conducted by Gary Freed and others, more than 80% felt that their training had been adequate for well child care, critical care, and most pediatric subspecialties, while 62% indicated they could have used more training in mental health, and 48% wanted more training in behavioral and developmental pediatrics. It's time we listen to our graduates and recognize the very large gap between the needs of children, adolescents, and their families, and the preparation of pediatricians to meet those needs. Our goal should be to train pediatricians who can counsel parents in efforts to prevent behavioral and mental health problems, identify those problems when they occur, counsel and treat most common problems, and refer and coordinate care when additional expertise is needed. The new morbidities identified by the 1978 Task Force on Pediatric Education were probably not really new then, but it was understandable that infectious diseases and life-threatening illnesses for which treatment was unavailable or limited had monopolized the efforts of pediatricians in previous decades. In 2015, we can no longer deny that behavioral and mental health concerns are morbidities that threaten the health and, in some cases, the lives of large numbers of children, their families, and society. It is my opinion that if the education of general pediatricians does not advance to meet this need, it will be difficult to assert, as the second task force on the future of pediatric education did in 2001, that pediatricians have the most advanced education and training to provide the best care for infants, children, adolescents, and young adults. So what should we do? I believe every pediatric residency graduate should be expected to be competent in assessing and managing patients with common behavioral and mental health problems before they are considered eligible to sit for the certifying examination of the American Board of Pediatrics. To achieve this goal, programs will need a robust curriculum and effective assessment tools. The mental health competencies for pediatric primary care, developed under the auspices of the American Academy of Pediatrics, should be adopted as a guide and initial curriculum, along with the residency curriculum that the Academy has already begun to put online at www.aap.org/mentalhealth. Most importantly, programs will need to deploy their trainees to environments in which they will be taught by experienced clinicians who are skilled in providing appropriate care and educating others. Ideally, the environment will be an ambulatory site and will allow residents to work in a longitudinal fashion in partnership with general pediatricians and behavioral and mental health providers. Community practices that integrate or co-locate mental health providers into their practice would be ideal training sites for residents. The American Academy of Child and Adolescent Psychiatry is well aware that pediatricians are not able to meet the mental health needs of America's children, and they have expressed willingness to partner with pediatric organizations and training programs to enhance the capacity of pediatricians to provide mental health care for common problems. It may even be possible to co-locate pediatric and child psychiatry continuity clinic sites to enhance the training of both groups of residents. Recognizing that addressing behavioral and mental health problems in the community pediatric office takes time, it will also be important for the Academy and others to continue advocacy efforts for adequate reimbursement to allow pediatric practices to provide the care children need and for which pediatricians will be better trained. Pediatricians have an opportunity to define themselves in relation to the needs of America's children. If we don't ensure that graduates of our training programs are prepared to meet those needs, the relevance of pediatric care to the health of children will be significantly diminished. Thank you.